Speech will be by Dr. Natasha on an algorithmic approach in diagnosing and managing posterior uveitis.
Thank you, Dr. Shane. So we are going to look at how we can proceed systematically in diagnosing and managing posterior uveitis. So posterior uveitis is inflammation that involves the choroid, but the choroid and the retina being so closely involved, often it involves the retina also. And the causes can be infectious, non-infectious inflammatory and masquerade syndromes. So just a broad list of the differential diagnosis for pan-uveitis and posterior uveitis. The infective, of course, tuberculosis, syphilis, leprosy, herpetic, Lyme disease, toxo, and endophthalmitis also comes into the same group. Non-infective sympathetic ophthalmia, VKH, sarcoid, Behçet's, and juvenile idiopathic arthritis. The masquerades, because endophthalmitis is like a gray zone, you can't really call it a posterior uveitis, so it's put in both masquerade and lymphoma, and trauma comes under masquerades. Now, what all questions do you need answers to when you see the patient? One, is it posterior uveitis alone or is it a part of pan uveitis? So how inflamed is the anterior segment? Is it a choroiditis primarily, or is it a retinitis, or is it a retinochoroiditis? Is there associated involvement of the optic nerve head, associated involvement of the retinal vessels? Does the clinical feature fit, once you have done all this, then does the clinical feature fit into any known infective or non-infective entity? Is there associated anterior segment inflammation, vitritis, or any complications that have come in from the disease being there for some time? Is it associated with any systemic features that you can see on your own without the help of a physician? Is it recurrent? And if so, how did it respond to previous therapy? Is it associated with an immunocompromised state? Is it finally, always ask yourself, is it a masquerade? Is it not a posterior uveitis at all? So let us look at the approach. History, of course, you can look at the age of the patient, the gender of the patient, ethnicity, the history of medications, past ocular history, pre-existing systemic conditions. Some of them will come in to you telling you that he has this and this problem. Careful clinical examination, a dilated retinal examination. I cannot emphasize this enough. So many patients are treated in primarily as an anterior uveitis without dilated examination to look at the posterior segment and associated anterior and intermediate uveitis. Now, if it is a retinitis, then your point of focus should be, is it a focal retinitis or is it a multifocal retinitis? Are there multiple areas of retinitis? And they appear as fluffy yellow-white areas with poorly defined margins, which can be focal or multifocal. The differentiating point between retinitis and choroiditis in your clinical examination is that retinitis will obscure the overlying vessel. Choroiditis, usually the overlying vessel will be clearly visible. So that is one point. There are a lot of other points also, but that is one point you can keep in mind. Now, a focal retinitis, the most common cause that we see now is toxoplasmosis, but you can also get it in Behçet's. Behçet's is one of the very few non-infective retinitis causes. You can get a retinitis patch in Behçet's disease. So that is one thing you can keep in mind. You can also get it in masquerades. Multifocal retinitis, syphilis, acute retinal necrosis, where the retinitis will be in the periphery. We look at, see, the whole thing about algorithmic approach to uveitis is mostly about, it is a pattern recognition. So you have to recognize which pattern does this fit into, and that is what is going to guide you in the next part of how to investigate. So this is the first part I'm trying to cover is how to recognize patterns. So CMV retinitis is multifocal, candidiasis is multifocal, PORN is multifocal, Duchenne is multifocal. So all these conditions, sarcoidosis is multifocal, but not mostly retinitis, but mostly vasculitis. Now, toxoplasmosis. We know that the typical pattern is that there will be vitritis, so it is a foggy appearance, it is focal, there will be vasculitis, venous vasculitis, and arterial sheathing, the chiraliasis arterialis, which is just arterial sheathing, and you will get venous vasculitis. Typically, you can get venous vasculitis away from the lesion. In other conditions, like you have CMV or ARN, the vasculitis is in the area of the patch, but here in toxo, you can get vasculitis away from the patch. traction with disc drag, peripheral traction bandwidth, not so much vitritis. In a child, it is probably a toxocariasis. ARN is multifocal, it is peripheral, there will be vitritis, it is in an immunocompetent patient and it heals with necrosis. CMV, central healing, central portion will be active, healing edge will be there. There will be associated hemorrhages, usually in an immunocompromised patient, more central than peripheral. That is how you can clinically distinguish between ARN and CMV. Now, another finding that you have to go deep into is retinal vasculitis. If you see vasculitis, find out if it is predominantly a venous vasculitis or an arterial vasculitis or are both involved. So the differential diagnosis, there is a huge list. Later on, I've made a chart of what are the investigations that you can do. You can even stick that up in your clinic. You don't have to keep it all in your head. So if you have venous vasculitis, I will send for this, like that. So these charts are available everywhere in literature. So predominantly arteritis, you are going to think of SLE, polyarteritis nodosa. Predominantly phlebitis, you are going to think of sarcoid and TB. And if you have arteritis plus phlebitis, you are going to think of conditions like Behçet's. Syphilis also can affect both arteries and veins. So this is venous vasculitis. You can see very clearly that it is only the veins that are involved, and it is patchy, and it is a very typical, what is it called? Candle wax drippings, very typical candle wax drippings. Arterial, of course, you will usually have occlusion along with it when it is an arterial vasculitis, because they don't just get sheathed, they get occluded. So you will see patchy retinal whitening around it. So arterial vasculitis, combined occlusive. Here you can see there is whitening of the retina with a large amount of hemorrhages. So here both the artery and the vein have been occluded by vasculitis, and this was the FA of the same patient. So other features that you can look for are, is there exudative macular detachment? Is there cystoid macular edema? Is there an epiretinal membrane? Is there retinal neovascularization because of the occlusive vasculitis, or a secondary VH or pre-retinal hemorrhages? Are you looking at active choroiditis, or is it a choroidal neovascular membrane? Is there any detachment associated? Is there any neuroretinitis? Next is choroidal inflammation. So your choroiditis can be again focal or multifocal, and the causes vary. So if you have focal, so TB comes in both groups. It can either be focal, we'll go into TB a little later. It can be focal or multifocal, but we know that focal choroiditis, other conditions that can cause focal choroiditis are fungal, candidiasis, chikungunya, sarcoidosis, and multifocal, mostly tuberculosis, but West Nile virus, sarcoidosis, idiopathic multifocal, all your white dot syndromes, they all cause multifocal choroiditis. TB can present in myriad ways. So you can have peripheral venous vasculitis, you can have focal or multifocal choroiditis. You can have, the one point to note is that the lesions are arranged along blood vessels. So if you have choroiditis that is arranged along a major blood vessel, then think of TB. That is why it's also called serpiginous-like choroidopathy. So you can cause serpiginous-like choroidopathy. It can be an abscess, it can be tubercles, it can be small dots, it can be miliary, present as exudative RD and posterior sclerosis also. So this is one patient with extensive vasculitis, and this is another patient with multifocal choroiditis, optic nerve involvement. You should look for cystoid macular edema. Now, approach to management. Once you have identified the characteristic fundus picture, you have to now confirm with specific investigation, treat the cause if it is infective, use inflammatory therapy if it is inflammatory. When you're not sure of the diagnosis, avoid deposteroids, avoid your Ozurdex or posterior subtenon, etc. if you're not absolutely sure that it is not infective. And if you are in a diagnostic dilemma, you must do a TAP. Now, cues to find out if it is infective, it is usually unilateral, moderate to large KPs, raised IOP, retinitis, immunocompromised patient. Syphilis can be there in any kind of features. Just I'll quickly show you one case before I stop. So pattern recognition is what we said is most important in posterior uveitis, but this is a case where pattern recognition went horribly wrong. So 40-year-old lady who presented with multiple sensory neural detachments, and FFA showed proper pinpoint leaks. So we made a diagnosis of VKH, started the patient on steroid, and the patient came back 2 weeks later with severe posterior scleritis and orbital cellular inflammation like picture. New lesions now appeared, choroidal lesions in the fundus, and Manto was strongly positive, necrotic. We did a PCR, it was also TB positive. So pattern recognition can go wrong. So always err on the side of infective, rule out infective before you decide on immunosuppression. Imaging can help you, both photography, autofluorescence, FFA, ICG, and that should again be based on your clinical examination. Systemic investigation, again based on your clinical examination. This is the list I said. There is a systemic screening workup list that is present in literature. You can just copy it in your clinic and then send the relevant investigations based on your Sun classification of uveitis. This is another case where there was a suspicion of both carcinoma and TB. So patient had TB spine and patient also had adenocarcinoma lung, came with a mass like this in the fundus. So we were doubtful whether it is a secondary or whether it is TB. And the B scan didn't give us much information. The FFA also didn't give us much information. So finally we went in to take a tissue diagnosis and it was TB. So we would have given a bad prognosis saying it is, CA secondary and send the patient off. But here a tissue diagnosis helped in telling us and is completely resolved with ATT. So to sum up, after history, do a proper fundus examination, decide is it retinitis, choroiditis or both, focal or multifocal, vasculitis present or not, if vasculitis is there, arterial, venous or both, peripheral or central, immunocompetent or compromised, optic disc and macula affected or not, exudative RD present or not. Use imaging modalities, systemic and serological workup, but be ready for surprises and use a tap or biopsy when necessary. Let me take this opportunity to invite you to Ignite 2025 on January 4th and 5th at Kochi. Thank you for a patient hearing. Sorry for overshooting.
Thank you, Dr.